Hello and welcome everyone to our Ask the Expert session. Is it Thursday? Yeah, Thursday lunchtime. My name is Paula Hanford and I am the CEO of PSC Support. We put these sessions on at different days and at different times to enable everyone really to have the opportunity to join a live session. Just to let you know, though, that we do record these sessions and they're on our YouTube channel. And if there are any sessions in the future that you can't attend but would like to ask a question, then please do email me beforehand. I'll ask the question and then you can watch it back on our YouTube channel. My email is paula@pscsupport.org.uk. I am absolutely delighted to be joined this afternoon by Dr. Jess Dyson. Dr. Dyson is a consultant hepatologist at the Freeman Hospital in Newcastle and honorary clinical senior lecturer at Newcastle University. These are very popular sessions. This is a kind of a general session on PSC where you can ask whatever questions you like on PSC. And we know there are always a lot of questions. As always on these sessions, Dr. Dyson cannot offer individual medical advice, but will answer your questions in the best possible way that you can. Please ask your questions, put them in the comments section, and we will come to them well, maybe not in order. I tried to group them together in theme if I can. Quite difficult when it's live, but I do try and do that. But we will try and come to as many questions as we possibly can. But please try and keep the questions fairly short so we can get to as many questions as possible. As always, I'm sure you will join me in thanking Dr. Dyson for giving up her time today. She's got a very busy timetable. She's just come from clinic and has got meetings straight after this and probably won't find time to have some lunch today. So she's given up her lunch hour to join us and we're absolutely delighted. So welcome, Dr. Dyson. We are very grateful for your time. And if you'd like to take us through an introduction, then we will take the questions.
Lovely, thank you very much, Paula, and obviously to Maxine and Martina as well for inviting me. Now, I did have strict instructions, it would appear, that it was a Q&A session. I have prepared some slides and we've just done a bit of a cull of the slides, but just to go through a few things that hopefully are fairly relevant from a kind of patient perspective point of view. So I thought, so we all know a lot about PSC, but just to kind of remind ourselves, it's defined as a rare disease. At the moment, that it's felt to affect about 7 per 100,000 people in the population. But increasingly, we think it's increasingly common with time. And there's some recent data that was presented just a couple of months ago at the European Liver Conference, suggesting that actually by 2027, that rate will almost have doubled to 12 per 100,000. And if you look at PSC associated with IBD, as opposed to just inflammatory bowel disease by itself, that growth rate seems to be higher for reasons that we don't know about. Obviously, one of the very common questions is, why has this happened to me or my loved one? And we know that there is a genetic bit so in terms of risk and predisposition, but it's certainly not the whole story. Some of you will know that my kind of subspecialist research interest is into environmental factors and thinking about kind of lifestyle, diet, where you live, could there be some form of infection triggering? And diagnosis can be a challenge. We don't have a good single test. And ursodeoxycholic acid, some of you will be on this medication, others aren't. It hasn't traditionally been recommended in the UK guidelines, but the updated European guidelines last year do now recommend urso. And this is just, as I say, some of the data from my PhD, which was called EALD, so Environmental Factors in Autoimmune Liver Disease. And we did this all in the northeast and North Cumbria. We have a really good mix of kind of urban and rural landscapes, so you can look at different types of environment, and a pretty stable population, about 3 million people, and low migration rates in and out, which makes it easier to look at disease epidemiology. And I spent many a happy hour across all our hospitals in the region, trying to identify all patients with PSC. And the picture on the right there is the study area, and then the hospitals, the green spots, as you can see, are all over the region. And overall, we collected about 500 patients with PSC. As many of you will know, it's predominantly a male disease. And as we've said, a point prevalence in my study of kind of 8.6 per 100,000. And just some of the clinical data, actually. So we collected detailed information about 462 patients. As expected, nearly 70% were male. The average age at diagnosis actually was slightly higher than we see in other studies, so 50 as opposed to 30 to 40, although men were diagnosed at a younger age than women. And one of the factors that seemed to be associated with this was that you were diagnosed at a younger age if you also had inflammatory bowel disease. There were different types of PSC, so some people just have their very small bile ducts inside their liver affected, but most patients have large duct disease, so the bigger bile ducts both outside and inside the liver. And in Newcastle, in our region, most of our PSC patients in the region are looked after in Newcastle, but we actually have a high rate of liver biopsy. A lot of patients with PSC don't get a biopsy, but I think this probably is the reason we have more patients with small duct disease than in other series. And the top right image there is an MRI scan. The vast majority of you will be familiar with MRI. And this is a scan to look at the bile ducts, finding narrowings and then kind of dilations or ballooning behind those narrowings in the bile ducts. And the bottom right picture there is of a liver biopsy. I don't know whether you can see my pointer, but that's a bile duct, and around it you're meant to get this kind of classic onion skin type scarring, so rings of scarring around the bile ducts. And we said inflammatory bowel disease very common, again with, as we would expect, about 70% of people had IBD as well as PSC, and the majority of patients have inflammation affecting their whole colon, so a pancreatitis, with a smaller proportion having Crohn's. And actually only 1 in 10 people had active disease, and about 1 in 5 people had their colon removed, whether that was for kind of bad IBD or for abnormal cells on biopsy or for colon cancer. And by far the commonest medications were 5-ASA, so that's things like mesalazine, octaza, pentasa, again, which some of you will be familiar with. And thinking about practically, so we've said that actually IBD is very common. So all the guidelines say that if you are diagnosed with PSC, you should have a colonoscopy when you are diagnosed, unless of course you're known to have IBD already. And if you have inflammatory bowel disease, you should be getting a colonoscopy every year. And even if you don't have inflammatory bowel disease, you should be getting a colonoscopy every 5 years to make sure it's not developing, because probably about 12% of people get IBD. Higher cancer risk if there was active colitis, and this is why we go hunting. So even if you don't have symptoms, some people, if you look into their colon and biopsy, they can have inflammation that can't be seen with the naked eye or doesn't cause symptoms, and that needs treating in order to reduce the risk of cancer in the colon. And interestingly, if you look at inflammatory bowel disease patients, up to about 20% in some series have MRI changes in their bile ducts, even if they have normal liver blood tests. And I wanted to think a bit about symptoms. My other, well, PBC, so primary biliary cholangitis, is one of my kind of other specialist interests. And we're very kind of aware and on top of symptoms in terms of PBC, but I think this is often under-recognised and under-acknowledged and under-treated in PSC. So we asked our patients, well, we didn't, that's not true. So we looked at the notes and looked to see what was documented by the doctors about itch and fatigue. And you'll see here that actually only 16% of patients had documented itch. More reassuringly, 75% of those were on treatment, and we'll come to think about treatment options. The vast majority were on bile salt sequestrants, so they're things like cholestyramine sachets, Questron sachets, and second commonest was rifampicin. But remember that figure of 16% having itch, because we'll come back to that. And itch, so I think we can learn a lot from PBC. They are both cholestatic liver diseases. So that means it's a bile duct problem. And if you ask patients, do they have itch? If it's a problem, they are immediately, yes, absolutely. And if I say, describe your itch, almost everybody will say it's worse at night, it's worse when I'm hot. Clearly, we need to make sure there's nothing blocking the bile duct. So at the very least, an ultrasound and an MRCP or an MRI scan. And just remembering that iron deficiency causes itch, or certainly it makes itch worse, and that's easily treatable. We have lots of medications, which I'll run you through. And then there are some more invasive physical therapies. So you can stick a drain into the liver, into the nose, straight into the bile duct. I'm not a big fan of that. I think it's very poorly tolerated generally. And then you can do MARS, which is actually a clever type of almost like dialysis. And actually liver transplantation is a curative problem for itch for both PSC and PBC. But obviously that's a massive operation. And we can only do that if we've excluded every other option for treatment for itch. And let's do simple things first. Well, the bile salts are questrans, I mentioned. So questran cholestyramine, many of you in the audience will be familiar with this, and it can be pretty unpalatable. It's quite sloppy. And actually, if you struggle to tolerate the sachets, we use the tablet alternative. So that's colesevelam. And next up is rifampicin. So actually, rifampicin is an anti-tuberculosis antibiotic, but it's actually the medication with the best evidence base for itch treatment. I think people are sometimes anxious about using it because it ironically does carry the risk of a liver injury, but actually it's a really good medication. We can use it safely, close monitoring, and I'm a big fan of rifampicin. Beyond questran and rifampicin, there are then a number of other treatment options. And really this is about individually tailoring treatment. What works for one doesn't work for another. And we work through a kind of treatment ladder, again, based on PBC, but there's no reason for us to think that it should be different. In PSC, we use gabapentin, we use naltrexone, we use sertraline. Gabapentin you'll be familiar with potentially as actually a painkiller, and sertraline is actually an antidepressant. The data in terms of clinical trials is very limited for those medications, but each one of those I have excellent improvement in itch in some patients. And the more recent or kind of newer kid on the block, bezafibrate, is very much in the forefront of people's minds at the moment, both in terms of blood test improvement in PBC, but also itch management. And the trial, the Fitch trial, which was looking at fibrates in itch, hence the Fitch. So actually bezafibrate improved itch significantly for both PBC and PSC patients. And you may get two for the price of one because it may make your liver blood test better as well. And I think increasingly we're kind of advocating for it to slot in at about the same level as rifampicin. Again, most of these medications have at least some risk. Bezafibrate can cause problems with kidney function. It can cause problems with liver injury. And you certainly can't use it in people with advanced cirrhosis, and definitely not jaundiced patients. And fatigue, the kind of great unanswered question really in PBC and PSC. I think many of you will probably relate to bad fatigue, and people have described the kind of cognitive symptoms as kind of brain fog or feeling like you're wading through cotton wool. And we don't have good drug treatments for fatigue, but we need to remember to look for other things. We all know that PSC patients often have other immune system disorders, so check the thyroid, check for anemia. Vitamin D deficiency, easily treatable, can help. Sleep apnea, are you snoring? We can do kind of sleepiness scores, and actually if you snore and obstruct your airway slightly overnight, that makes you really tired during the day and again is treatable. Have you got other factors? Are you low in mood? Are we giving you medications that make you fatigued? And we all know that when we're, exhausted, that actually the last thing we want to do is get up and going. But actually that's the worst possible thing we can do. We very much try and encourage activity. And there is evidence that kind of graded exercise programs can help fatigue. And certainly in PBC, fatigue is often worse as the day goes on. So we kind of encourage people to kind of front load their day with their activities. And this graph here on the right is PBC data, but again, I suspect if we did this in PSC patients, we would see the same thing. So quality of life impairment related to symptoms is actually the greatest in the younger patients. And PBC-40, so this is one of the symptom assessment tools designed specifically for PBC, but I think many of the symptom sets that we see in PBC is map onto PSC, and I think we can learn a lot by sharing information between the two diseases. And not that surprisingly, none of these things happen in isolation. If you're itchy and it's worse at night so you don't sleep, well, it's probably not that surprising that your fatigue is worse. So we need to manage your itch well. Your social interactions, what you do, where you go, impacted on. People often feel embarrassed if they're scratching in public. It may affect what they do. If you're fatigued, obviously you may interact less on a social level, go out less. So I think it's really important that we take the overall view rather than just thinking about each of these things in isolation. And in Newcastle, we developed this kind of concept of trace. So this is really about trying to empower patients to take some control. Fatigue is a massive issue. We can't treat it with medications. We need to remember to look for other causes and treat those. We need to try and manage the effects of fatigue and help people cope with the effects fatigue have in their life. And I think importantly, clinicians are really bad about acknowledge, or not all of us, hopefully some of us are not so bad, but we need to really encourage clinicians to ask about these symptoms and try to understand the impact. And people often need, adjustments to their working patterns, for example, and we can support applications for that where it's appropriate. And sadly, as we know, PSC is associated with cancer in some patients. Hepatobiliary cancers are one of our real problems. So by that, I mean bile duct cancer, gallbladder cancer, or pancreatic cancer. I can't spell cholangiocarcinoma, it would appear. And sadly, bile duct cancer is the highest rate of diagnosis within 1 year of PSC diagnosis, and a lower risk with small duct disease. And with the gallbladder, we monitor for polyps. And actually, if you have polyps in your gallbladder in a PSC patient, we would take the gallbladder out sooner with smaller type polyps than we would in somebody in the general population. And actually, there's recent data again presented at the European meeting a couple of months ago, actually was probably more reassuring than we would have previously thought. So if you exclude the people within a year or two of diagnosis, if you then follow people up over a longer time, actually the risk of cancer in the hepatobiliary area is about 2%. And interestingly, there's a slightly lower risk of hepatocellular carcinoma in patients with cirrhosis associated with PSC as compared to cirrhosis of other causes. We're not sure why that is, but it does seem to be the case. And people often ask us about, well, what can we do? How do we look for cancer? How can we check for cancer? And it is one of our big problems and one of the worries for patients and their families. Guidelines would suggest a scan every year or 6 months in some units, either with ultrasound or MRI. This is really about not just waiting for problems to happen, it's trying to search for problems before they present in terms of symptoms. And this information from Scandinavia, where a lot of the very good PSC data comes from, does demonstrate that actually if you are doing regular kind of planned imaging and scans, actually that is associated with improved long-term survival rather than just a watch and wait approach and waiting for problems to develop. And bone health, I think, the liver is obviously what we think about a lot, but actually we need to think about the wider picture. So patients with cholestasis, so either PBC or PSC, you don't absorb the fat-soluble vitamins as well. So vitamin D deficiency is very common. And actually somewhere between 20 and 40-ish% have osteoporosis. This is something we can help in terms of lifestyle. Weight-bearing exercise is very good. Stopping smoking, minimizing alcohol, diets high in calcium and vitamin D. And doctors should be formally assessing risk of osteoporosis. So the FRAC score is a kind of plug your numbers into a computer algorithm and it gives you a risk. And we should be doing bone mineral density scans, so DEXA scans for people. And then treating obviously according to our findings, and that usually includes vitamin D supplementation and a bisphosphonate. So many of you will be familiar with drugs such as alendronic acid. And there are now more recently a number of other medications available for osteoporosis. And probably one of the commonest questions I get from GPs about PBC, PSC is actually, this person's got a high cholesterol, can I give them a statin? There's a lot of anxiety about statins and liver disease, and actually abnormal lipids or cholesterol are very common in PBC and PSC. Traditionally, it was thought that these were actually not the kind of bad cholesterol and that they didn't associate with increased risk of stroke or heart disease. But I don't think we should be falsely reassured, and I would advocate that all patients are assessed just as anybody else in the population. We tend to use the Q risk score for this. GPs, it's absolutely their bread and butter. They have lots of expertise. We think about family history and other risk factors, for example, smoking. And statins and fibrates are safe in PBC and PSC. I would exclude advanced cirrhosis, as we've said, with fibrates. But people are not at increased risk of a complication from a statin as per the general population. They can cause abnormal liver blood tests, but you as an individual with PSC are not at increased risk of that. So if you need cholesterol management, then I would suggest that that is valuable. And actually, just to touch on some of the data, which I think the PSC support group were absolutely central to developing. So this is, again, presented at the European meeting a couple of months ago, massive survey, nearly 800 people. And I think this points to what I was saying earlier, that we are under-recognising symptoms in PSC. So actually, nearly 90% of patients said they had at least one or more symptoms, and 60% of people had itch. Now, you compare that to the data I showed you earlier, where only 16% of people were reported as having itch. So I think there is a clear mismatch between what the patients are telling us and what we're seeing. And even more worryingly, 50% of them had never had treatment. And antihistamines were being used. There is no evidence for antihistamines in itch in PSC. And actually, if you give a sedating antihistamine, that makes things worse rather than better, potentially, in terms of the fatigue. And 3/4 of people were describing fatigue, which is a really massive proportion. And in terms of kind of patient empowerment and actually going to your doctor and saying, these are my problems, these are my symptoms. Itch, we have lots of treatments. We should not be tolerating itch without, working through those options for treatment. 8% of people had never had a colonoscopy. 1/4 of people had never had a fibroscan, so that's a way of measuring stiffness in the liver, and we would advocate that as part of routine assessment. Half of patients had never had their bone mineral density assessed, so they'd never had a check for osteoporosis. Although on the upside, about 40% of people had been approached regarding trials or research. So I think there's some really important factors there. Think a lot of things for clinicians to learn, and also to try and give patients that knowledge to be able to go to their doctors and say, I've never had a bone scan, we need to do one of those, for example. So there's a somewhat abridged version. I hope that was of some value in terms of, and more than happy to take questions.
Oh, that was great, Dr. Dyson. I'm sure everybody appreciated that introduction. So we'll move to the questions. I've got some questions, some general questions to start. And the first question really supports it's about your work really in the environment, those environmental factors. And the question is this: are there any specific areas in the UK where there is a high prevalence of PSC? And I suppose a follow-on question would be, why, if there is, why do you think that is?
So I have another set of slides about that, which I've taken out of that talk. But so my work particularly looked at the North East and North Cumbria. So that's quite, it stretches, I suppose, across the top of England. And yeah, undoubtedly, the study I did, or we did, across the region, did show kind of hotspots of autoimmune PBC and PSC. So there do seem to be areas where there was a higher risk of PSC. So there are clusters of patients living in certain geographical areas, and there are higher rates of PSC patients in some areas than others. And that data would suggest that, yeah. And the same is true with PBC.
Why do you think that is? Why have those clusters? I know this is the $1 million question.
The $1 million question. No, indeed. So I mean, I think we are all increasingly believers, for want of a better word, that the environment is playing a part here. Now, whether that is pollution, toxins, something you're exposed to at home, something you're exposed to at work, infection, people who've seen, I did do a talk previously for you guys about my research. One of the things, or the kind of things that highlighted in my work, was heavy metals, so arsenic particularly, actually. So heavy metals are processed, are dealt with by the bile ducts. So it's quite interesting to see that there were high levels of arsenic in areas where there were high levels of disease. Now, what that means, you know, in terms of what we do about it, there's a big difference between association and causation. So just because we see high levels of something doesn't mean it's causing disease, but it's certainly at worst an interesting observation, and I would argue does definitely need further assessment. The two other kind of specific notable findings in my research were, if you look at, you can assess kind of levels of urbanness, if that's a word, or rurality. And if you looked at our patients, I mentioned that in the northeast and North Cumbria, we've got a real mix of kind of urban landscapes, rural landscapes. We've got very big cities, but equally we've got big expanses of kind of hills and farms, etc. And actually the rates of PSC, so it was associated with more rural areas, which is interesting. So actually you think of towns and cities as being where there's lots of pollution, there's lots of traffic, etc. But in PSC we were seeing higher rates in more rural areas rather than in the big polluted towns. Now, interestingly, the absolute opposite was seen in PBC. So in PBC it was much commoner in urban areas. And then I think one of the other kind of very interesting findings, almost always there are higher rates of disease in areas where people live that have levels of social deprivation, so lower levels of income, for example. But actually PSC rates where there were higher rates of income, and it's the opposite to what we see in
I don't know if it is.
most of the information is
Dr. Dyson, I think the internet went very strange.
Oh,
then.
sorry. Is that back again?
Yeah, we're back now. You're back now. I don't know if you could just repeat the end of that answer. I didn't catch it.
I was just saying about social. Did you hear that I was starting to talk about social deprivation?
Yeah.
Did you get to that? Yeah. So almost all diseases are higher or more common in areas with high levels of social deprivation. So poorer areas, lower incomes. Whereas actually we found the opposite in PSC. So actually the rates of PSC were higher for areas which had kind of higher levels of income, more affluent areas, which is a very interesting observation.
It is very interesting. This is another thank you very much for that. This is another general question. What is the oldest PSC patient you see at your clinic?
Oh, we've got people in their 80s, probably early 90s. I mean, we do undoubtedly have patients with PSC who we've looked after for decades, who really haven't had any significant change in their disease, and that, you know, so yeah, absolutely, some in their 80s, and I suspect I'll probably have a few in their early 90s.
That's really interesting, and I'm sure good to hear actually for those who are listening. This is a bit of a statement and then a question from Craig. Currently watching while having my infliximab infusion for IBD. I have PSC IBD diagnosed quite recently in March this year. Consultant said he's in a high risk group for transplant and possible bowel removal. I know you can't give an individual medical advice, but general timescales for something like that would be, it's very difficult to say, I know, but I don't know if you want to comment on that. What would be the general timescales?
you can't
No.
you can't really. The problem with PSC, I suppose, is there's so many variables. You know, IBD, sorry, inflammatory bowel disease, controlled, not controlled, small duct, large duct, levels of abnormal blood tests, etc. There's so many variables. I mean, as I say, I literally have patients who we've looked after for decades who have never run into problems, even those who've got large bile duct disease, which traditionally are higher risk. And why some of those people come for decades, never have any problem, and not wanting to but will die of something other than their PSC in due course, versus, as you know, yes, some people get transplanted for PSC. It's, you know, it's an unavoidable truth. But I think one of the things that is helpful when we first meet somebody, I think one of the things that is valuable is rate of change. So if I see you at 1 year, 2 years, 3 years, if things are absolutely unchanged, your FibroScan is normal, your ducts don't seem to be changing, clearly that's a reassurance. Whereas if people are developing more significant abnormalities or scarring in their liver, I think rate of change can be informative.
Yeah, well, that's really interesting. Somebody's got their hand up. We don't take questions from individuals. You need to put them in the comments box. Apologies for that. Can gallbladder removal affect the progress of PSC or cause complications? And the poster said, I've been recommended it following several episodes of cholangitis, but I am worried.
Yeah, so I think I'm not aware that gallbladder removal makes the rate of progression of PSC increase. I think that's probably what's being asked. Undoubtedly, if you have the episodes of cholangitis, so infection within the bile ducts, if those are related, if people have gallstones and actually what's triggering those episodes is the gallstones moving around, getting stuck in the bile ducts, then if you take the gallbladder out and thereby remove those gallstones, then actually gallbladder removal potentially is a very good treatment for that. In the same way as somebody without PSC, I mean, gallstones are very common in the population, and a proportion of those people have their gallbladder out. So I think in the and if, you know, every operation comes with risk, of course it does. But removal of the gallbladder for cholangitis being triggered by stones is I think a fairly is a very reasonable thing, and obviously it requires probably additional assessment in PSC. You want to make sure there's no stones in the bile ducts in the liver, for example. And obviously any operation, if somebody has very advanced liver disease, so advanced cirrhosis, any operation is more high risk. But yes, gallbladder removal in itself, and equally for, you know, polyps, as I mentioned in those slides, would be not. I don't think there's evidence that increases disease progression in PSC.
Okay, that's good to know. Thank you for that. This is a question about liver transplantation. We always get questions, you know, quite understandably about that. What percentage of adult PSC patients, this poster has put no IBD, do end up needing a liver transplant? A liver transplant.
That's a very interesting question, and I'm not sure I know the answer to that, if I'm honest. I would be I probably have slightly biased experience in it. So because I work in Newcastle, which is a transplant unit, I probably have a slightly biased view on that, because of course, if you have high risk disease or you have advancing liver disease, you're referred to us. So my PSC, I look after almost everybody in Newcastle as a city, as a catchment area of PSC, but I have most patients around the region, but it probably is a slightly biased group. I can reflect on that.
What we might do, Dr. Dyson, is we can put comments on the session, which is on YouTube, so we can find out that figure and put it onto the video. So we will do that. The next question is about, I think it's about ERSO, although the poster hasn't actually said that. Now that the EU guidelines say it should be considered as therapy, should patients who are not on it consider asking their consultant to be put on it?
So I shall declare myself as an ERSO fan. So all my patients are on ERSO. I think my rationale for that, so the kind of the reluctance, and certainly the UK guidelines when we wrote them, and I say that as a co-author on the UK guidelines. So I came from the fact that there isn't a controlled trial of ERSO versus a placebo that demonstrates that people live longer or get less complications from their PSC. However, the strength of things like UK PSC and the international PSC kind of groups is that actually, if you look at big cohort studies and follow people over time, ERSO probably is associated with improved blood tests and better outcomes. So that's kind of what we would call real world data. So drug trials and clinical trials are clearly very important, but I think what happens in the real world, we can learn from that. So, and the other anxiety about ERSO was that in very high doses, it was associated with complications. So we would definitely not give massive doses of ERSO. Personally, I just give the same doses I would give the PBC patients in my care. So yes, I think it would be very reasonable to start ERSO, and I think that, you know, as we've said, the European guidelines were changed last year to include it, and although the UK guidelines haven't done that as yet, I suspect they will probably follow suit. As an individual clinician, all my patients are on ERSO, unless they can't tolerate it, are on ERSO.
That's interesting. Thanks very much for that. There's a couple of questions about families with PSC. One about how possible is it to pass it on to your offspring, and the other one about, are you seeing families with multiple PSC patients?
No, I think that's one of the probably the real kind of key question or key concerns for people, isn't it? You get a diagnosis, and you know, are you going to pass it on, particularly in a disease which is often diagnosed in a kind of childbearing age group? So we mentioned there is a kind of genetic bit of PSC, but it is not a genetically inherited disease. So you don't pass it from mother or son, mother or father to child, if you see what I mean. To the degree that we don't, so we don't screen for PSC in family members, and we would not. You don't need pre-pregnancy counselling, for example, about disease risk. And if you think, so even if you've got a higher risk of disease in a family member, if you take a rare disease, so PSC in its own right is rare. So even if you have a slightly increased risk in a family member, that's a very small risk, you know, in a rare disease already. And I think I look after, so PBC, the genetic risk, I've probably got a handful of families with more than one patient, or more than one family member, and I think I have one family with 2 PSC patients,
right? And
that's it. And I've got, I mean, quite a lot of PSC patients. So I think, although I think it's a very live question for people, and obviously a entirely obvious and sensible thing to be concerned about, I think the likelihood of multiple people in the same family is very low. What we do see, in fairness, is families that have a kind of immune system overactivity. So it's very common if, you know, when you come to see me in clinic and I say, oh, has anyone got rheumatoid, or has anyone got hypothyroidism? That is fairly common.
Right. Yeah.
So the kind of immune overactivity in a family is fairly common, but PSC, and it isn't being passed on. So we would try to reassure people about that.
I think that's really good to know, especially if you've been newly diagnosed. It's a really good answer to have, actually. The next couple of questions are about diet and exercise. So the first question is, in your view, should diet have more focus in terms of research and how it affects the progression of PSC?
Yeah, no, I think that again, it's one of the things people ask a lot, I think probably at least so PSC patients as a kind of, I mean, this is a big generalization, but are very engaged in their care, quite keen to take some ownership, try to do things that they can to improve things. And I think, if we're being very honest, some of that is because we don't have lots of treatments. You know, in a disease where I can give you 10 different tablets or injections to make you better, there is probably less of a feeling of, oh, well, what can I do? What else can we do? So I think yes is the answer to the question. I think we probably should be thinking more about diet, lifestyle, etc. I mean, broadly speaking, what is good and healthy for the general population is good and healthy for anybody with liver disease. You know, being of a healthy weight, not, I think the way I think about it is, let's not challenge the liver with something else. You know, we don't want, just because you've got PSC doesn't mean you can't get fatty liver disease, doesn't mean you can't get alcohol related liver disease. So actually, if you're very overweight, if you're diabetic, if you've got high blood pressure, all of those are risk factors for liver disease. So we don't want to add to the burden or the challenge to the liver. The other thing I would say, though, in terms of lifestyle, and it's not really diet, but the thing about I've seen about 3 or 4 people in my clinic this morning actually who said, well, I don't drink alcohol. And I know this seems like quite an odd thing to say as a liver doctor, but if you don't have advanced liver disease, the feeling that you have to be completely abstinent from alcohol is, there isn't evidence that alcohol causes autoimmune liver disease, and some people don't want to drink alcohol because they feel like it's something they can control. But you know, there is not evidence that a bit of alcohol does you harm in PSC, and there was not evidence that your lifestyle gave you PSC. So even if you used to drink more than might be recommended, that doesn't mean it's your fault you've got PSC. So I would just, I don't, as I say, it sounds slightly odd, but I tend to kind of say, yeah, feel free to have a bit of alcohol. Somebody asked me to document it today so he could show the letter to his wife. But yes, so I think, broadly speaking, healthy diet, avoiding very processed foods. There is some data that kind of, it's quite old data now, but kind of high amounts of fish in the diet may be good. But I think particularly given the interlink between the gut, i.e. inflammatory bowel disease, and PSC, it makes sense, doesn't it, to think that the diet is important, and we probably place too low a focus on that, because of course that's a relatively easily changeable thing.
Yeah, so the next question is about exercise. And the question is, would a gym and a personal trainer make the situation better or worse if you are mildly fatigued?
So I think, yeah, I touched on that a bit in the slides, and I think, as I say, so there's a difference, isn't there, between I feel a bit tired versus what patients with PBC and PSC. And I think one of the frustrations for, not wanting to speak on behalf of patients, but I mean, we are a symptom specialist centre, so part of what we do is look after people who have a really high symptom burden. And I think what frustrates many people is a lack of acknowledgement that what I feel as I don't have PSC or PBC, what I feel as being tired and fatigued is not the same as our patient group, and this kind of sensation of hitting the wall and the batteries running out and all those descriptions. But actually, and it's difficult, it's easy to say and more difficult to do, exercise and keeping active and exercise programs are probably one of the best things in terms of managing fatigue. And in the absence of us having a good medication, it is really about lifestyle, and certainly, as I say, graded exercise. Another thing, to be honest, we should put more focus on in fatty liver, non-alcohol related fatty liver disease. There's a big focus on activity, weight loss, those types of things, lots of research. The same would, I think we would very actively encourage exercise, whether that be with a personal trainer or self guided. But I think, yeah, being fit is good for you.
Definitely. Yeah. Okay, so the next question is about treatment, potential treatments and cures.
Mm.
Pushing aside that no one can predict the future, and I know that clinicians, you know, are not all on the same page as this either. So what is the timescale that clinicians are expecting a direct treatment cure for PSC, e.g. years or decades?
Yes, now that is so. Yeah, I think that's an important distinction, isn't it? Treatment versus cure.
Yes,
now,
is.
Clearly, what everybody wants in every disease is a cure.
Mm.
But I think in reality, we are a long way off that. We have to understand why a disease happens, broadly speaking, in order to cure it. Having said that, I think treatments is a more positive place. You know, one of the challenges, frustrations for PSC patients and the clinicians, the doctors, is the fact we don't have a good evidence-based treatment. The landscape is changing, though, I think. You know, traditionally, I mean, my specialist interests are PBC, PSC, and autoimmune hepatitis. And PBC for years, I mean, almost decades now, there have been lots of trials. There have been people trying to push forwards, and all of a sudden, we do now have good or better, and you know, more than one treatment. So there are. PSC is well behind the curve. Autoimmune hepatitis, to be honest, is probably even further behind the curve. But the drug companies are coming on. So there are two different types of research, aren't there, and looking for treatments. One is drug company or pharmaceutical company led, and the other is kind of investigator led. And PSC is really coming to the fore. So the drug companies, pharmaceutical companies are now realizing the importance and the burden of PSC, and there are lots of trials now. Until relatively recent times, there being almost none. And likewise, investigators, and by that, sorry, I should be clearer, doctors or clinicians or researchers setting up their own studies without it being drug company funded, but getting funding from some, for example, some of the national research bodies. And I think the other strength we talked about rare disease. If you've got heart disease, you've got millions of people with heart disease. So getting a trial of heart disease tablets is relatively easy. In a rare disease, that's a real challenge. But one of the absolute strengths, I think, of the PSC, well, autoimmune liver disease as a community is the fact that everyone's kind of clubbing together. Collaborating might be a posher word. So actually all the trials pretty much that are ongoing involve lots of centres, so lots of hospitals, not just in the UK but internationally, so that we're able to get enough patients into a trial to try and answer the question. So I think I think the activity and knowledge of the patients, and I have to say, I mean, I know you invited me to speak, but I am genuinely, I think PSC support, as an example, you know, spreads the word, spreads knowledge, spreads information, gives people awareness of trials. So I think those two strengths as clinicians and patients alike. I think treatments are coming through. There's lots of trials of various mechanisms of action. Antibiotics, for example, there's kind of come in and out of vogue. Bile acid treatments. So the treatment landscape, I think, will probably change fairly markedly within a number of years.
Yeah, and of course, PSC support have committed £1 million to try and find this effective treatment as part of our Mission 2030 campaign. And we've just had our first funding round, so we'll be able to announce what we funded shortly once those contracts are signed, but there's some exciting research that will take place as part of that campaign as well. There's a couple of questions here about statins, because you mentioned that.
Am I going to regret mentioning statins?
Maybe, I don't know. First one is, I cannot take a statin as I am on, I've got to try and pronounce this right, ciprofloxacin. Yeah, that's true.
Is
that right?
So although I said statins are safe in PSC and PBC, that is true, but it's like you couldn't. So clarithromycin is another antibiotic you can't take a statin with, but that would be true whatever the reason you were on that tablet, if you see what I mean. That's not a disease specific problem.
Right.
So it's the interaction between the medications. It's not because you've got PSC, if that makes sense.
Yeah, it does. Okay.
So for and another, so I suspect another question might be this. So bezafibrate or fibrates and statins in combination is also can be done, but has to be done with caution, and you have to dose them slightly differently. So, but again, that's because of the interaction of the medications, not because the patient has PSC or PBC.
Okay, well, you can tell me if this question is around that. Did you say that it's okay to take statins even if the liver enzymes are upset by them? Patients with high cholesterol, heart disease, and this poster takes ezetimibe.
Ezetimibe. So no, I didn't say that. I said,
okay.
Or that's not how it was. So statins can cause abnormal liver blood tests,
right,
in anybody. So the general population, a proportion of people who get given a statin then get abnormal liver blood tests. What I meant was that risk of a problem with a statin is not higher because you have PSC or PBC than it would be if you were, didn't have those diseases. So a lot of, high cholesterol is phenomenally common in the population, and generally speaking, broadly speaking, and you do have to individualize it, and I would always, make sure I was giving advice relevant to that specific patient. But statins, as a general rule, are not something I would say cannot be given.
Right. Okay. Thank you very much for that. We've got 8 minutes to go. We'll take as many questions as we possibly can. We still have a few to try and get through. I've recently been diagnosed with osteoporosis. You mentioned this in your slides. I've also have portal hypertension and varices. It's still safe to take, oh gosh, I wish I could pronounce these names a little bit better. Bisphosphonates, which apparently can irritate the esophagus. Yeah,
again, that's a very common concern, and I think probably is a reasonable concern. Any of you who know, so bisphosphonates are once a week tablets, generally speaking, and they have to be taken. You have to sit up for half an hour afterwards because they do cause inflammation in the gullet. So traditionally, it was said that the evidence didn't support them causing problems. Equally, nowadays, there are lots of other, you can have an intravenous bisphosphonate on an annual basis. There are lots of other drugs now, but osteoporosis is not my specialist area, but things like denosumab. So there are other options available. So I think if somebody has kind of reflux or have significant varices, then I think it probably is reasonable to err on the side of caution and not use one of the oral bisphosphonates, because they do undoubtedly, in a proportion of people, cause problems with the esophagus.
Thanks very much. Microbiota. Has any wide-scale, detailed, profound gut microbiota sequencing been undertaken of PSC patients? And if so, what has been noted?
Yeah, so again, microbiome is one of the other kind of very hot topics, but to be honest, in every disease pretty much. PSC obviously is kind of a hot topic, partly or a lot because of the IBD PSC association. Your gut and your liver talk to each other. I mean, not literally, but talk to each other. So yes, there's a lot of work going on. There's lots of clever assessment of your microbiota, generally bacteria, fungi, etc. Some of that is quite high level kind of sequencing of those bacteria, and comparing the microbiome or the bacteria in your gut between PSC patients versus healthy, whatever that means, healthy people versus inflammatory bowel disease patients, and there are differences. And you can potentially change the microbiome. So actually, there's loads of things that affect it: diet, bile acids, even mood. Actually, interestingly, affects the gut bacteria. Obviously, medications. So, I mean, this is part again of where the query about antibiotics as a treatment for PSC comes into play. Because actually, if we can change essentially get rid of the bad bacteria, I sound like a probiotic advert, don't I? But it is the idea of kind of shifting the bad bacteria, and some of the kind of lactobacillus there's lots of, I mean, there's millions of species of bacteria, but yeah, your bacteria in your gut do seem to be different in disease versus not diseased. I think one of the concerns, you didn't really ask this, but one of the concerns about the antibiotic-based trials in PSC is, do we run the risk of just making us have resistant bacteria that we then can't, which are actually, could they be bad bacteria that we then can't treat? Now, there's a recent trial of vancomycin, for example, and one of the kind of concerns about that was whether we were breeding kind of tricky bacteria to treat. Actually, the data probably hasn't shown that. They're still doing lots of analysis. It's kind of very early doors analysis from that trial, but that is one of the things that there are some kind of, we do need to bear in mind.
Yeah, sure. We might get 2 questions or maybe just the 1 question, but I'll see how we go. I live in rural.
Shorter.
Pardon?
I can give shorter answers.
No, I think you know, some of them require longer answers, don't they? So I live in rural Oxfordshire. I've always walked my dogs through the fields. I've never been particularly bothered about walking through the fields after they've been sprayed or fertilized. Would it be wise to rethink this? This is interesting. My dog died of liver cancer in 2021, just before I was diagnosed with PSC, which is a weird coincidence.
Yeah, and I think that's one of the dangers, isn't it, of the environmental studies? And I say that as somebody who ran one of the biggest ones. I would be very wary of, as I said, association is different to causation. And I think the evidence for activity, healthy lifestyle, get out and about, walk your dog, being good for you is extremely convincing.
Yeah.
I think the evidence of doing the, you know, as you say, fertilizers, pesticides, sprays, the evidence for that causing disease is weak at best. So I think getting out and walking the dog sounds extremely sensible.
I think this is probably going to have to be our last question. My son is recently diagnosed with Crohn's. Should I ask his doctor to check for PSC?
Yeah, no, I think that's a important and very sensible question. I think generally speaking, in patients with inflammatory bowel disease, because they get monitored routinely, they'll get assessed. The things that will trigger assessment of the liver is if the liver blood tests become abnormal. So we wouldn't, in this country, as it stands, we don't screen for PSC in inflammatory bowel disease patients. It's a, you know, I think it's very reasonable to say to the doctor, you know, have we done some liver blood tests? Are they normal? I think that's a very reasonable question. Yeah. But as it stands in this country, we don't screen.
I'm going to take 1 more question.
Yeah, that's fine. It's all right, yeah.
Having a transplant young, under 30, can be beneficial, of course, if you need it. What are the risks?
That's a very broad question.
It is.
I mean, I suppose the risks of transplant are, I mean, broadly speaking, the risks of transplants are the same whenever you have them. I mean, the converse to that is actually, I suppose, if you're old, say if you were 70 and you have other medical problems, then your risk at the time, one of the reasons we don't transplant potentially is because if you had heart disease, for example, you know, we can give you a new liver, but you as a whole person needs to be fit enough to get through a massive operation. If you're and broadly speaking, the risks are the same for, you know, the tablets you need. So you need immune suppression, carries risks. Obviously, there's the kind of early short-term risks surrounding the operation itself, and then kind of infection risk, and longer term, as I say, the immune suppression risk. Those risks in terms of, you know, complications around the surgery, infection, long-term complications of immune suppression are the same however old you are. Those risks exist. And broadly speaking, I suppose we want people to be as old, you know, we'd like you to get further in your life before you need a transplant. That's why we're looking for treatments to postpone. I mean, there was a limit to age in terms of fitness for transplant, but ideally you would like to push the transplant further down the road if you're very young.
Great. Thank you very much. We're now at 2 o'clock, and I know you've got other meetings to go to, so we'll finish there. And I'm sorry to all those people. Thank you very much to all those people who have asked questions. And I know that there's some questions we didn't get around to answering or asking even. We had 29 questions and some very detailed questions as well. So thank you very much for everybody who's asked those questions. And thank you, Dr. Dyson, for giving up your time today and giving us some really clear answers to the questions that people have. And we'll be inviting you back if you would come back to do some more sessions in the future in 2024 now, actually. The next session, we're not having a session in August. We are taking a break. We think people will be on holiday. So the next session will be Saturday, the 2nd of September at 1 p.m. with Dr. Deepak Joshi. And again, it'll be a general PSC ask your questions. So those of you who haven't had your questions answered this time round, can I suggest you come onto that one and ask them early on, because they have got more, more likely to be asked at that point. So thank you so much, Dr. Dyson, and thanks everyone who's joined us today. Thanks very much.
Thank you very much. Thank you for the
Bye-bye.
invitation. Take care.